All right, good evening, everybody. Want to welcome you to tonight's webinar. My name is Darren Schumacher, and I'm the Director of Marketing and Business Development here at OSMS. Tonight, we have Dr. Joe McCormick with us to talk about total shoulder replacement surgery. And just so you are aware, we are recording this webinar, and the recording will be made available on our website at osmsgb.com/webinars by the end of the week. If you have a question, please leave it in the Q&A box, and I will be asking Dr. McCormick your questions after the presentation. So before I turn it over to Dr. McCormick, I have a few facts about OSMS that I'd like to go over with you all. And if we look at the next slide, just want to talk a little bit about OSMS. So we are a doctor-owned orthopedic, sports medicine, rheumatology, and pain management practice. We have 9 locations throughout northeastern Wisconsin. We're actually just about ready to open our Oshkosh clinic, our own clinic in Oshkosh, and that will be open April 13th. So we're very excited about that. We do have 25 orthopedic doctors, 8 rheumatologists, and 3 pain management doctors. But what's important about the number of physicians we have is that we have access. We can get you in quickly. If you need to make an appointment and you're in pain and don't want to wait to see a physician, we can typically get patients in, especially on the orthopedic and sports medicine side, if not the same day, the next day. The next slide. We do have a full range of services at our locations. So diagnostic services like X-ray, MRI, CT scan, bone density. And then we also, in Neenah and Green Bay, we do perform a test called EMGs. And so that's something that also we can offer our patients. And then again, kind of continuing with the full range of services in one location. We do have infusion treatment on our rheumatology side. We do have 2 independent orthopedic surgery centers, one in Neenah and one in Green Bay. We have 2 walk-in injury clinics in Neenah and Green Bay, and when Oshkosh, our clinic in Oshkosh opens, we will have that. And that's where you can walk in and see a physician without an appointment. So if you have a new injury, think of it like an urgent care for injuries, and you walk in, but you get to see an orthopedic physician without an appointment, as charged as if you had an office visit. So it's charged as if you made an appointment, even though you're walking in. So there's no emergency or urgent upcharge. And then lastly, we do have physical and occupational therapy at our clinic locations. We work with different partners for that, and so we're proud to provide just that full range of services in one location. Another thing we know our walk-in clinics aren't open 24 hours a day. So we did come up with a free chat program called Ortho Access by OSMS. And you can use that 24/7. Again, it's free to use and you get advice. So it's not an appointment, but you do get advice. So if you have a new injury or pain, find out, is this something I should make an appointment for? Is this something I should use your walk-in for? Is this something I should just rest in ice and see how it is in a day or two? And you can get that advice for free 24/7. There's no app download. It's all web-based, but it's just a great way to just get peace of mind on a new pain or injury. And then last, before I turn it over to Dr. McCormick, at our Green Bay and our Neenah clinic, we recently expanded hours. So Monday through Thursday, we are now open until 7 p.m. and we take appointments until 7 p.m. We also accept walk-ins until 7 p.m. So that's something that we heard from our patients. We got feedback that it was sometimes hard to get off work, and this way people don't have to do that for appointments. Or again, if an injury happens and it happens after 5 o'clock, you can walk in and be seen at our Neenah or Green Bay clinic. So with that, I am going to introduce Dr. Joe McCormick, who's going to talk about total shoulder replacement. So Dr. McCormick, welcome.
Yeah, thanks, Darren. I really appreciate the intro and the opportunity to talk a little bit about something that's kind of near and dear to my heart, and that is shoulder replacement. Both talking about the pathology of problems with the shoulder and also talking about what kinds of treatment options that we have, sort of the success rate, the history of these things, how we select the correct patients, things like that. So my name is Joe McCormick, as Darren mentioned. I am a physician owner at OSMS. I am from Wisconsin. I grew up here in Wisconsin, and I'm happy to be practicing and raising my family here in Wisconsin. This is my 24th year in practice here in Wisconsin. I trained both at Medical College of Wisconsin in Milwaukee and also did my residency training in Denver for 5 long years. So anyway, a little bit of an overview moving into the topic of shoulders. I wanted to talk a little bit about, for starters, the biomechanics of shoulders and how that kind of works, and then talk about the history of the different kind of replacements. And there's at least 3 different kind of replacements I wanted to be able to cover tonight and talk about the differences with, and then cover again patient selection and some results. So within shoulder biomechanics, talking about how a shoulder moves, but specifically talking about how it is that I can start with my shoulder low and raise my shoulder high overhead. In general, the rotator cuff is the muscle bundle that is responsible to initiate that movement and help me to raise well overhead. And the motions that do that include a net motion that moves medially or toward the midline, and then a net motion that moves upward so that I can literally raise my arm overhead. But in order to do that, the shoulder forces have to stay as a ball and socket joint centered directly within that ball and socket joint so that the motion will raise overhead. And so that's just a little bit about how rotator cuff helps to create the centering effect of the ball within the socket. Now, a common problem that we see in shoulders would include a problem of what we would consider to be a force imbalance, or opportunities where the ball does not center in the shoulder, but instead rises up and stops or bumps into the shoulder. And in that sort of a situation with a rotator cuff problem, we'll find that the person isn't able to raise overhead. They're only able to partially initiate that movement. An example of seeing that in the X-ray would be to see the head, the humeral head itself, ride high, which we call superior migration. And that when that occurs, we get that unstable rotation, so the ball and the socket don't articulate right, and I just can't quite get myself to raise full overhead when the rotator cuff is working well. It turns out that rotator cuff is one of the things that is very important to make the distinction between different kinds of patients who come in with shoulder arthritis. Typically, when we're treating shoulder arthritis, we're talking about treating pain, and almost always that's arthritis, sometimes with rotator cuff problems, and sometimes even with a history of an old rotator cuff repair that either did or did not take. And then lastly, we also see typical patients who have either had fractures or broken bones related to their shoulder, or have had improper healing of those bones over time, and then with that have developed a painful arthritis. So again, that's a nice little overview of the kinds of patients we see that need to think about shoulder replacement. Our total shoulders nowadays have gone through sort of a revolutionary design, and the newer designs that I'm going to talk about today are almost always designed to both relieve your pain, and the kind of shoulder that we're talking about at first, at least, would be one that's stable as long as the rotator cuff muscles are intact. We're almost always looking for shoulders that will allow for full overhead generous movement. And just as an example, total shoulder replacement for nowadays is a day surgery. So you come in the morning and you leave that afternoon, and that's the day surgery design. This is a sketch that I found of the artificial joint, and it's kind of a nice a little overview. It does show the combination of the ball, which is a metallic ball, as well as the socket, which is an all plastic socket. And that's implanted both in the humerus bone or the upper arm bone, and then the socket itself is involved in the scapula, which is also referred to as the shoulder blade. And you can see in this particular diagram that the ball and the socket are very well articulated right together, and that sort of balance helps to allow proper centering of the head and helps to allow for motion that can raise all the way overhead. So this is an example of total shoulder replacement. Now, the newer designs that have made a nice revolution for us in orthopedics is the reverse total shoulder. And in this kind of a situation, the reverse is very useful, both in the same vein to help relieve pain, but it can function with only the deltoid muscle and does not require an intact rotator cuff. It's inherently stable and sort of stays in place. And again, this surgery is similar to total shoulder replacement, and that is a day surgery. On this particular prosthesis, I'm showing, again, instead of the ball and socket being located together, in this case for the reverse shoulder, the shoulder is taken apart. Where the socket used to be, a ball is placed, and where the ball used to be, the socket is placed backwards so that the shoulder remains captured and moves smoothly from the seated position to all the way overhead, but with the ball and socket functioning on the reverse side. Whether the surgery itself be a total shoulder replacement or a reverse shoulder replacement, the surgery takes about 90 minutes. And for recovery time, we usually talk about using the sling for an initial period of protection for about a month. And then after the 1 month time frame, we begin movement. Full recovery is typically expected at about 3 months. And a lot of times, at least 80 or 90% of the time, formal physical therapy is not always used. So this is the kind of a surgery that you can go through with a motivated patient, and a couple of home exercises can go from that protocol of starting in the sling with the initial period of rest and then eventually moving to movement to the point where patients can raise all the way overhead. Of shoulder tasks that we like to talk about, a lot of my patients afterwards can raise 100% all the way overhead. But at a bare minimum, most patients can raise at least up to about hair height, which is kind of important to be able to wash your hair, style your hair, or putting on clothing. And then I would say, again, for the vast majority, we look to be somewhere between hair height and raising all the way overhead, with the result from either shoulder replacement or a reverse shoulder replacement. With regards to results long term, the current designs are really, really excellent. And a lot of the designs, especially in reverse shoulder replacement, changed about in the late 2000s. So right about 2007, 2008, 2009, a lot of those newer designs that I use nowadays were initially sort of invented. And a great number of the American companies have all followed those design parameters and do excellent. Trying to decide about a rotator cuff, a total shoulder replacement versus a reverse shoulder replacement, the rotator cuff is key. For patients who undergo any kind of arthroplasty, we typically would expect that they'll last very, very well, up to about 15 years. They are some of the happiest patients I have in my clinic. The shoulder does not dislocate and has good stability, relieves pain, and improves motion. And as I mentioned, about 100% of patients can raise that arm at least up to their hair height, and a great number of them can raise somewhere between hair height and raising all the way overhead, pain-free, which is really, really excellent. In olden days, I only had a prosthesis known as a hemiarthroplasty, where there was only a replacement of just the ball, not the ball and the socket together. And in that sort of a situation, patients usually had good pain relief, but couldn't raise the arm very well. On the left-hand side, I do have a picture of that hemiarthroplasty, which is a single ball replacement. On the right-hand side, I'm showing an x-ray of the reverse shoulder replacement, which is largely replaced hemiarthroplasty for patients who are rotator cuff deficient, meaning that rotator cuff is not guiding that centering into the center of the socket. And so therefore the reverse design helps to create stability and allows for overhead movement that's reliable and that is pain-free. So I dig through the archives quite a bit, looking back at old cases. This happened to be one of my first cases. I first met this patient in 2008, and she did have surgery in 2009. It was an 85-year-old woman living in assisted living, and on that right arm, that was her dominant arm. She really could not raise overhead and had that humerus migrating quite a ways north. And so, with that sort of a situation, the ball was not staying centered, and so she could hardly raise overhead at all. On the right hand side was what her reverse shoulder replacement looked like. The new ball was placed where the socket was supposed to be, and then the socket was placed where the ball used to be. And that did restore her to be able to raise overhead, to be able to put on her clothing, to be able to do her hair, to be able to put on a jacket and sleep comfortably at night. So that was my first case, and a really happy case with a nice, pretty x-ray. So that's what I included for tonight's talk.
All right. Coming back on. So, all right, Dr. McCormick, thank you so much for that presentation. I know that was some really good stuff that we had there. We did have a question come in, and again, if you have questions for Dr. McCormick, please go ahead and put them in the Q&A area. We did have one that talked about the long-term weight restriction. The person did mention too that they're a 66-year-old male, but what would be the long-term weight restriction for somebody with a shoulder replacement?
So I get a lot of different questions about aggressive, especially outdoor activities. But I've had patients that go back to shooting shotgun in their trap league successfully. I have patients who go back to their bowling league, which is an underhand movement with regards to bowling. But when you use a bowling ball that's 14 or 16 or 18 pounds, you do generate a fair amount of torque at the shoulder, trying to hold it up and trying to control that through the bowling movement. As far as just plain lifting, we don't encourage a lot of full overhead presses like in a military press, but with things like bench press or for pushing and pulling, whatever the patient could tolerate before, they can certainly work back up to that. And there isn't really necessarily a long-term deficit or restriction to doing that.
All right, thank you, Dr. McCormick. Some other questions we have here are, what are the most common causes that lead someone to need a shoulder replacement?
Yeah, that's a really great question. I mentioned some of them in the talk related to either rotator cuff injury from whatever injuries those come from, a slip or fall, or even being in a car accident, and also fractures. But arthritis in the shoulder is a little bit unique in that we don't walk on our shoulders. So I don't necessarily have a lot of patients that walk in with a shoulder that's related to too much weight bearing or activities like that. By contrast, because I do take care of hip and knee replacement patients or patients with ankle problems, we do walk on our hips and our knees. And so, in a lot of ways, you can think about activities that we do on our lower extremities, and they do create wear patterns. In the shoulder, we don't really walk on our shoulders that much, but oftentimes it's folks who do heavy lifting or farmers, things like that, that end up being activities that can sometimes wear out the shoulder prematurely. And then another big group of patients who have rheumatoid arthritis or Lyme's disease or lupus or other kind of inflammatory arthritises, they will affect upper extremities a lot. And so we'll see patients like that as well. You may have to take your mute off.
You know what? I did. I had it on mute. I apologize. I'm sorry. The question is, are there any non-surgical treatments that a patient should try prior to considering shoulder replacement?
Yes, and we do have a myriad of patients, excuse me, of providers that do that kind of thing. For patients with inflammatory arthritis, it's good to have a rheumatologist or to meet with a rheumatologist who can help with maximizing the medical treatment for the arthritis that's present. But we also consider injections in the area and physical therapy an awful lot for patients who have early onset of arthritis to try and treat that without a surgery. With regards to relative rest, that's good also to try for shoulders, although there are certain tasks that we kind of all have to be able to do in order to wash and put on clothes, put on a jacket, things like that. So there are some activity restrictions related to trying to be careful about things that we lift or raising overhead, especially in overhead presses. But for pushing and pulling or lifting real close to our body, there's not really much you can do with most of that. But mainstay of non-surgical treatment would be medications, injections, or therapy.
All right. Thank you, Dr. McCormick. Remember to, if you have a question for Dr. McCormick, please leave that in the Q&A box. Another question that came in here, how do conditions like arthritis or rotator cuff tears contribute to needing a shoulder joint or a new shoulder joint?
So with rotator cuff problems, we find that the shoulder doesn't stay centered directly in the socket. And as that ball does not center, the sliding around creates extra wear around the shoulder. And so that's a very common mechanism by which we either see that proximal migration or just damage internally to the shoulder. And sometimes that stems from shoulder dislocations in a younger athlete or in a younger patient. But sometimes it's just related to a rotator cuff injury, which could happen from a serious fall or even a car accident or falling off a ladder or things like that. And then lastly, of course, fractures, broken bones can definitely lead to arthritis at a youngerish age and would be maybe one of the reasons we would also see shoulder arthritis for shoulder replacements.
All right. Thank you again, Dr. McCormick. Another question here. How do you determine which type of shoulder replacement is right for a specific patient?
So that's a really great question. I was hoping for the most part that I tried to answer that one today. For the most part, looking at the damage within the shoulder, the key becomes the rotator cuff. And if the rotator cuff is intact and is strong and healthy, then the person is a good candidate to consider just a total shoulder replacement or even a hemiarthroplasty. But if the rotator cuff is not functioning well or isn't anticipated to function well or is already thought to be torn beyond repair, then the reverse shoulder replacement becomes the real answer for that kind of patient. Again, both of those are day surgeries, and both of those have a nice success rate since about the mid or late 2000s. But the difference in trying to determine between those two would almost always be the condition of the rotator cuff.
All right. Another question. This is a good one. Is there an age that is too young for a shoulder replacement?
Usually, the kinds of things that cause shoulder pain leading to advanced arthritis do occur in patients that are over 65. That's kind of one of the average ages I see. And it really are patients even up to 70 or 80 for sure. Under 65, I think definitely would be considered a very young patient. But it wouldn't necessarily be the record to consider either from a bad car accident or bad inflammatory disease, someone in their late 40s or early 50s, if they had shoulder arthritis, to consider a replacement. Again, the one unique thing that we're finding in studying long-term outcomes from shoulder replacement is it is a little bit hard to predict what percent are going to be worn out after 15 or so years because we don't really walk on our shoulders. So if the person goes back to a relatively reasonable lifestyle, we have seen shoulder replacements that definitely last longer than 15 years and maybe even longer than 20. It is also possible to have a redo of shoulder replacement. So again, for that younger individual that maybe has to consider arthroplasty, later in their life, they could consider a redo of that maybe at one point.
All right. Another question we have here is, what are the biggest risks or complications that I should be aware of?
So that's also a really, really good question. Um, as with a fair number of orthopedic surgery, the biggest risk probably comes from the anesthesia in general. And so a lot of times we involve your family doctor or a cardiologist or pulmonologist or other doctors who help with care around your overall health to sort of gauge whether or not you'd be able to tolerate the anesthesia well, and what would be the best plan for you in particular. Um, Also, there's risk around possible dislocation, although it's very, very low, and also risk around infection, but also very, very low. Um, so really the biggest risks come around the anesthesia that's utilized and whether or not you'd be safe for anesthesia. And then maybe lower on the totem pole would be things like infection or things like um, having some kind of an instability or dislocation.
All right, just a couple more, it looks like here. Um, is there and I think you covered this in the presentation, but I think it's a good point to hit on again, is what is the recovery time after a shoulder replacement, and like when can you return to, regular activities, whether that be, work or sports or other things?
Yeah. So again, with shoulder arthroplasty, we do sort of limit things for that first 1 month to the tune of wearing a sling and kind of taking it easy. And then after that 1 month is completed, we tend to begin therapy program on its own. And with that um, therapy, we're looking to improve the ability to raise overhead, light pushing, light pulling, all of those things. The full recovery probably takes anywhere up to about 3 months, and then maybe after that to work on gaining strength. And that depends on what the person really wants to get back to, because I find that a lot of different patients bring different expectations to what it is that they're trying to get back to doing in their life. But yeah, overall, I'd say that first 1 month is pretty difficult, and you're in the sling a lot. Month 2 and month 3 are more designed to begin to restore motion overhead and use the shoulder more normally, with good results or feeling really, really good after about 3 months total.
All right, and this may be our last question of the night, but what kind of improvement in pain and function should someone realistically expect with total shoulder replacement?
Yeah, so some of the major problems that we see when patients have shoulder arthritis is they can't get dressed very easily. It's difficult to be able to put on a bra or put on a t-shirt or your jacket. And so those things realistically you can almost always get back from. When it comes to being able to style your hair or reach overhead, again, at least reaching up to hair height is very much expected after shoulder replacement. A good number of patients can reach higher than hair height, but being able to at least reach hair height is expected in 95+% of patients. So I would say things related to personal care, dressing and jackets, being able to do your hair, put on clothing, put on underarm deodorant, things that become difficult to do when you can't move your shoulders out are definitely expected after arthroplasty. The other thing that comes up a lot is having a comfortable night's sleep in almost any position. Whereas we find when we have a lot of shoulder arthritis, it's hard to find a comfortable position for sleep, whether that be laying on the affected shoulder or laying on the opposite shoulder, and even finding that the affected shoulder sort of slouches either forward or backward and still hurts when you're trying to get comfortable sleep. All of those things really can be expected to be relieved with shoulder arthroplasty.
All right, and right as I said, that might be the last question. Two more questions came in, so I think we have time to answer those. So, how would a total shoulder replacement hold up to repetitive motions such as kayaking, canoeing, or cross-country skiing?
Boy, that's a really, really excellent question. One nice thing about shoulders is that the way that God designed our shoulders is there's not a lot of stress related to shoulder activities that are at or below shoulder level. So when I find folks that like to do repetitive activities, cross-country skiing or kayaking, and working in that below shoulder motion, the shoulder is very conducive to that and does not find a lot of wear in that particular activity. So those are pretty safe to think about. It's when I meet folks who like to lift weights or do kettlebells or military press overhead, or hitting a volleyball or throwing a baseball overhead. That's a little bit more difficult to predict, and especially predict that long-term expectation of how long you'll be able to stay doing that. But those particular things that are at or below shoulder level are very well tolerated, and usually you can get back to those with good results.
Excellent. All right. So a question about how the surgery is done. Is it done laparoscopically? Laparoscopically, easy for me to say tonight. And then what type of scarring would someone expect?
Right. So there's a large number of shoulder surgeries that we do in general that are arthroscopic, meaning with tiny incisions and using magnifying cameras to be able to do the work. This surgery isn't like that. So the scar is just in the front of the shoulder, and we're able to sort of pull muscle to either side. Part of the muscles that are cut to be able to get at the shoulder for access, at least one of the muscles, is typically repaired back down, and that takes about a month to heal, and is one of the reasons why we do use a sling for about a month. But in shoulder arthroplasty, either kind, that shoulder is done open, with an open scar right on the front of the shoulder. And then, like I said, most of that initial healing occurs in the first month, so that muscles can then begin to be used after that, and actually begin to get strengthened as well.
All right. And then this might be our final question. What exercise do you recommend before the surgery?
So the exercises I love to see people working on are exercises for flexibility, either for raising overhead or stretching to the side or around the back, and try to maintain as much of that flexibility as we can. With regards to strength, I really like to see exercises related to core strength. And that's just because the muscles that attach at the shoulder are considered core muscles, and helping to maintain that is one of the things that really helps get the function back quickly following arthroplasty. Patients who have better, stronger muscles right from the start do a better job to be able to return that once they get through the surgery itself. Sometimes patients ask about max lifting or max things that they can do. And a lot of times that comes down a little bit to grip strength. So that's another one I like to see, is maintaining good grip strength and power in our grip, because again, afterwards, it just makes it easier if the grip strength has been maintained to find function later after arthroplasty.
All right, that looks like that was our last question. So I just wanted to thank everybody for their questions and for participating in today's session. We appreciate your engagement and hope you found the discussion valuable. Just as a reminder, there will be a recording of this presentation made available on our website within the next few days for all of you to play back if you wish. And if you have any further questions or would like to schedule an appointment with Dr. McCormick or any of our physicians, you can do so by calling 920-430-8113, or you can schedule online at osmsgb.com. Thank you again, and enjoy the rest of your night.